He's also a member of the Maine Children's Growth Council and chair of the Early Childhood Initiative. He completed his medical education at Case Western Reserve, University of Colorado Medical Center, and Boston Children's Medical Center. He also has a master's in public health from Harvard and did his pediatric residency at Harvard Medical School. Cindy Brown is the State Director of Early Childhood Special Education, Child Development Services in Maine. Most of you know that CDS is responsible for ensuring identification of children with developmental delays and disabilities of children ages birth through 5. So we're delighted to have both of them to talk today. And just for CME purposes, none of the speakers have any relevant financial disclosures for today's CME activities. So I'm going to turn it over to Dr. Holmberg. Thanks for joining us today.
Great. So let's start out with just an overview of the role of medical home in screening and surveillance. Besides conducting developmental surveillance, which is really well child care, for instance, led by the Bright Futures guidelines, and then the periodic screening, a critical role also is education of families and parents. Some great tools mentioned there besides Bright Futures would include the new Watch Me Thrive from DHS and the Department of Education. Key is to share the screening results with other groups doing screening. That's one of the big objectives of the talk today, is to appreciate these others are doing a similar screening, and we need to coordinate public health nursing in a lot of regions of the state, early Head Start, Maine families, and of course CDS. And then once we find an issue, a problem through screening, we really need to have a major role in connecting families with early intervention services and care coordination for further diagnosis. So just a brief mention, this new product has just been advertised, the Watch Me Thrive, that I think all of us need to take some time going on the website and learning about the products they have there for families. And just a brief overview, the developmental surveillance is mostly our well child care, our observation, our listening, using tools like Bright Futures, but then moving on at critical periodic ages with a specific validated screening tools such as ages and stages at 9, 18, and 24, 30 months, with a big emphasis that 30 months is about the last time we're going to have a validated screen done in our well child care before kindergarten. And then the autism at 18 and 24 months with a new revised MCHAT with a staged process where if there's over 3 questions of the 20 that are failed, so to speak, then one moves on to the more specific repeat of those failed concerns with the follow-up product. So the purpose of developmental screening, I think we need to always remember, is to emphasize and identify where the strengths are, besides identifying the risks for developmental delays. Those 5 big areas of communication, language, gross motor, problem-solving, cognition, social, emotional, and then the adaptive fine motor. Doing the screening at critical ages, that 9, 18, and 24 to 30 months, has really been identified by research as being the most important stages for early screening. It's not diagnostic. It's really an indication of risk, and requires a careful discussion with the family about action steps for further specific evaluation from the standpoint of determining an actual diagnosis, and most importantly, getting going with some early intervention services even before the evaluation might have been completed. So there's a lot of other groups doing screening, and some of the same as we're doing in our medical homes, particularly the AF2 Maine families. A real important group starting at birth and prenatally, even, to refer families certainly by 3 months of age, and they can follow families for case management besides screening up to 3 years of age. Early Head Start, if you're lucky enough to be in an area that has it, they're doing ages and stages. Public health nursing, the same issue. They're not all over, but there's some great nursing, public health nursing programs, I know, particularly in Bangor, besides down in Portland. And then, of course, CDS is doing fairly similar screening, but then going beyond the ages and stages to using the Battelle and others. So when things are on target, from a standpoint of working with our families and patients, reminding them that it's a screen for whether they're online within the normal sort of limits and boundaries, emphasizing the strengths. It's an opportunity to really provide some developmental stimulation information over the next months until we see them again for further well-child care and surveillance. But when the screening results are concerning, particularly important to remind the parents of the limitations of this. It's not a diagnosis, it's not a fail, it's an indication that some scores were below a cutoff. There are things that can really affect that. Certainly a bilingual child is going to have delays, apparent delays in speech according to these guidelines, and we know in the long run they're going to probably, most of them, catch up fine. A key thing, though, is to listen to the parents' concerns, just as if everything passed okay, was fine. The parent may still have concerns here. What are the parents' concerns when the results indicate some issues, and still emphasizing where the strengths are. And then as far as the specific follow-up, talking about next steps, I think this is the most important thing we can really document in our EMRs. Most often, check the hearing and vision if it's not been done before. The psychosocial stress factors at home can throw off a lot of the screening results, even if there's not specific developmental delays. So really dig into the psychosocial issues if you haven't before, and then discuss the referral options. Most specifically here in the 0 to 3 population, the early childhood referral to CDS is most appropriate, and then whether you think further medical evaluation with genetics or neurology, et cetera, might be appropriate. And then early on, in addition to referral to CDS for further evaluation, also considering other early intervention programs right off the bat. Main families, again, within those first 3 to 6 months is the age that they need to be signed up for if it's a teen parent, public health nursing, etc. And then if there's real multiple issues that need coordination, remember the wraparound case management if they're on Medicaid with various groups like WINGS, for instance. And more specifically, the next steps help the family coordinate the referrals, make sure you send results of your evaluation, your screening results over to the groups doing further evaluation, whether it's a group like the Behavioral Developmental PEDS at Eastern Maine or the CDS track referrals. I think it's really important in our offices to have someone who's a referral specialist and a care coordinator, and actually develop a registry in your EMR so that you know which patients have had an issue with developmental screening and those that you're referring off for further evaluation, so we can keep track of our numbers and quantitate the effect we're having. And again, if they're main care, to think about setting up for case management. And important to realize is a number of resources early on with that identified high-risk newborn those first 3 months. In the Bangor area, we're lucky to have a joint project at Eastern Maine for NAS babies with public health nursing and then the Maine Families group. Think of Maine Families as your earliest head start, if you will, working with families in their home. There's really strong evidence base over the country for these early home visitation programs in preventing child abuse and neglect besides other developmental disabilities. And I think at that point I will turn it over to Cindy.
Thank you, Dr. Holmberg. Hi, everybody. This is Cindy Brown, and I'm really glad to be participating in today's webinar. So for the next few minutes, we're going to talk a bit about child development services and what we are all about. The whole reason we exist, or entities like a CDS exist across the country, is because of the federal IDEA, or the Individuals with Disabilities Education Act. And that has its beginnings way back in 1974 with the passage of the first Education for All Handicapped Act. So it's been around for a while, and that really opened the doors to the public schools for kids 5 through 20 for the first time in history. It wasn't until the mid-1980s that some amendments were made to that federal law to establish and acknowledge the need for earlier services for kids in the preschool age group, ages 3 to 5. And then a few years after that, the acknowledgement that, hey, we really need to back this down and start at birth and start with our infants and toddlers in an early intervention program. And right now, all 50 states do participate in the federal grant application to get funding to provide both early intervention under what's known as Part C of the law and under Part B for kids ages 3 to 20. So a little more specifically about child development services, legally we function as something called an intermediate educational unit. And actually in Maine, we are now one IEU. Over the years, we've gone through some various iterations. As the law stands right now, we are one statewide IEU with 9 regions and multiple locations throughout the state. We are under the supervision of the Maine Department of Education, and as I just mentioned, we provide the early intervention for infants and toddlers through age 2 until their 3rd birthday. And at that point, it becomes the famous acronym FAPE, Free Appropriate Public Education, with services for kids age 3 and up through the public school system. I'm here in Augusta, and we have a central office. We have a central data management system. We're responsible for system-wide policies and procedures. We also provide the fiscal functioning for the entire CDS system statewide. At the local regional site level, we have staff in the offices and on the ground that provide case management, along with specialized instruction for both families and children ages birth through 5. And as Dr. Holmberg mentioned previously, we are in that front end of identifying and evaluating kids to determine if they in fact do have a disability under our regulations. So Childfind, just like public school special education, CDS is operating an entitlement program, which means kids are entitled to receive the services that they need under this IDEA law. Childfind services, meaning identifying, screening, and evaluating those kids to determine their eligibility, is provided at no cost or no out-of-pocket directly to families. And again, as part of our federal and state mandate, we are to locate and identify all the kids that might be in need of services. Referral sources, once this child becomes known to them and they have identified a concern or a delay, the law really encourages and really wants referral sources to get those kids referred to the early intervention and special ed system as quickly as possible. This is just a quick slide of who our referral sources are. Physicians are a huge referral source for CDS. I think we work very closely with medical homes. And then parents are our next largest group, and it goes through all the various and sundry other entities that are out there. This is a slide, and this will be available to you later, but it just hones in on where the 9 sites are, their addresses, phone numbers, and we also have a central referral line here at the state CDS office. And as well, you can now make a referral online, and this is just a quick snapshot of what the referral intake form looks like. As you can see, there's quite a bit of information that we do ask for, primarily demographic, and hopefully that is information that is readily known to the medical home folks. On our end, once we get a referral, either online or a phone call referral or a fax, our aim is to have at the outside a response in 3 days. I would say 9.5 out of 10 times the referrals are acted upon within the same day and a lot of times within the same hour. This just gives you a window into the complexities of what is in the IDEA. Sometimes I liken it to the IRS tax code. It is a pretty lengthy and verbose law. Part C is the section of the law that deals with little guys, birth up until their 3rd birthday, also known as early intervention for infants and toddlers. This just gives you kind of the meat of what children in Maine have to, the criteria that they have to meet to be eligible. So as Dr. Holmberg mentioned earlier, those areas of development, communication, gross motor development, fine motor development. The physical development also includes vision and hearing, social, emotional, and adaptive development. Maine does have a pretty rigorous expectation for kids that would meet the criteria for identification as developmentally delayed. It's a standard deviation of 2 below the mean in at least one area of those mentioned above, or a delay of at least 1.5 standard deviations below the mean in 2 of those areas. The next part is a really important piece that I don't think perhaps has been highlighted enough and is really important for folks at the medical homes to be aware of. The second pathway that a child can be found eligible for early intervention is by having a diagnosed physical or mental condition that has a high probability of resulting in developmental delay. And the federal government has some broad categories, as listed on this slide, of what they mean by diagnosed physical or medical condition that has a high probability. Things like chromosomal abnormalities, children with trisomy 21, severe attachment disorders, disorders secondary to exposure to toxic substances, including FAS, genetic or congenital disorders, sensory impairments, meaning hearing and vision loss, inborn errors of metabolism, congenital infections, and disorders reflecting disturbance of the development of the nervous system. These children are found eligible for Part C. They don't have to be demonstrating a delay in one of those 5 areas, as was noted on the previous slide. What they may get for services can vary greatly. They may not be demonstrating a delay in any of those areas, so perhaps service coordination or case management is the service that they may start out with, or it may be a consultation or consultative model they may start out with. But the key thing is, I think, to really be zeroing in on those types of infants and toddlers that you might be seeing in your practices, that making sure that they are, in fact, connected to CDS. Just real quick, I wanted to talk a little bit about our model. I think the word has kind of gotten out there on the street that we're using a coaching model, and I really kind of want to bump that up to the next level. Where we are going is towards full implementation of something called the routines-based early intervention model, and that was developed by an internationally renowned expert in early childhood special education, Dr. Robin McWilliam, and he is actually working with us here in Maine as we move ahead in this model. This is an evidence-based approach that really helps the family, the caregivers, or the adult learners in a child's life to gain competence and confidence in their ability to support the child. A hinge pin of this model is working on parent responsiveness to the child and really seizing the natural learning opportunities that are found within the context of everyday family routines, typically found in the home setting, but it doesn't have to be exclusive to a home only. This is a multidisciplinary team approach. One of the positives about this that we hear from families is they don't need to travel to multiple locations or make time for a laundry list of appointments in their lives every week. Another important part about early intervention is, where does it happen? The rules that guide our work tell us that it should be happening in the natural environment to the maximum extent appropriate. Natural environment is a home and community setting in which children without disabilities participate in those everyday routines, things like sitting and eating dinner with the family. This is another nuance of the law, but I think it's an important takeaway. The natural environment piece is really important in that if the team concludes that a particular child cannot meet one of their outcomes in the natural environment, our case manager has to write a sufficient justification as to why, and then there has to be a plan as to how the team will reintegrate or move that service back to the natural environment if they have to go to a more exclusive or restricted setting. So that's an important piece about natural environment. Just real quickly, moving on to the preschool population, this is a slide showing the eligibility criteria here in Maine for kids under the various disabilities. Not in any, they're in alphabetical order, not by order of occurrence. The eligibility for Part B, or special education, is a little bit different. The child has to need special education and related services because of their disability, and that these supports are needed for them to participate effectively in their and benefit from their educational program. The difference with special education, we've now shifted from the term natural environment to least restrictive environment, kind of the same underlying presumption, but that all children start out in an early care and education setting where children who are not identified with disabilities are also served. And there is a protocol to work through how a team might decide that a child needs a more restrictive setting to benefit from their education. Special education, in fact, is specially designed instruction, which is based on the unique needs of each identified child. Related services generally are thought of most commonly as speech-language therapy, physical therapy, occupational therapy, but the list is not an exhaustive one, and it may include other evidence-based practices that a team feels are needed for the child to benefit from special education. Timelines are different for the early intervention program and the special ed program. For Part C, for the infants and toddlers, we have up to 45 calendar days to complete the eligibility evaluation, do the family assessment, and conduct that first IFSP team meeting, which is the plan for the infants and toddlers. For Part B, we have up to 60 calendar days to complete the evaluation and determine that the child does in fact have a disability which requires special education and related services. So two distinct timelines, and the important piece there are the words up to. Certainly if we can schedule and get that child in sooner the better. Those are the maximum days that we have before a term that's near and dear to our hearts, we fall out of compliance with the federal expectations. Transition is a very important piece of the work that we do, and we have two types of transition primarily that we deal with. Transitioning our older children as they get ready to go to kindergarten, and transitioning our toddlers as they approach their third birthday. And we want to really get a lot of folks involved in that process so that it is as smooth and seamless as possible for the kids and the family. Paying for either the IFSP or IEP services. An important piece is that the screening, evaluation, and assessment is at no cost for kids 0 through 5, so under both Part C and B. The case management and IFSP development are also at no cost. So in other words, we are not allowed or permitted to charge families for case management services, nor do we exclude families from our case management services or service coordination based on whether or not they have Medicaid or other payment sources. We do have a sliding fee schedule or a family cost participation policy that actually I will be holding a public hearing on this spring for folks to participate in regarding the use of some parent funding and the uses of private and public insurance. Once a child turns 3, that FAPE provision that I spoke of earlier kicks in. So all IEP services are provided at no out-of-pocket cost to the family. Families may consent to allow access to their private or public insurance, but they are not required to do so, and their declining consent for that should not have any impact on their child's ability to access their FAPE services on their IEP. And as I wrap up, if a child isn't eligible for CDS but does have a need for service, they certainly should be staying in close contact with their primary care medical home to talk about other options, things like referrals to specialty providers. And some of the other folks that Dr. Holmberg mentioned, we work very closely with our community partners at Early Head Start, public pre-Ks, community nursery schools and child cares. So I think it's really important, again, that we kind of do a wraparound for this child and family to make sure that we can point them in the direction of supports, even if they don't meet the eligibility criteria for CDS. Children can always be re-referred if at a point in time we don't find a child eligible. We may develop an internal timeline with the family, a plan to reevaluate or rescreen in a period of time. Medical home can always re-refer after a period of time. They see that there are still concerns and the child is not making gains. So that's always an option up until they are ready to go to kindergarten. And I think the other piece, my final slide, is if a child needs more or a different service. Some families and primary care medical providers believe that a child may need other services or a greater frequency of services than what CDS is providing under the scope of their regulations. And that is certainly every family's prerogative. It's not CDS's role to tell a family what they may or may not do with regard to their own child. So the family or the primary medical home might refer them to a private practitioner or other agencies to access things beyond the scope of the IFSP or IEP. It's important for families to understand